Hello, we
It's
can't
very
hear.
difficult to unmute Vivian. So if you can please unmute her for me.
I've done that. When I ask you to unmute, you have to then unmute yourself. I've done that severally. Otherwise, you could just talk from your phone.
Okay, we're ready.
Okay. So once again, good afternoon, everyone. We are welcome to this week's presentation on tetanus. Dr. Mabel will be leading us in the presentation. And without much ado, I would welcome Dr. Mabel to start us off. Dr. Mabel, so over to you.
Okay, good afternoon. Please, I'm Mabel, and I'll be leading today's presentation on tetanus. So the outline for presentation will be an introduction, epidemiology, pathophysiology, predisposing factors, clinical manifestation, diagnosis, management, prophylaxis, and prognosis, then our reference. So tetanus is a nervous system disorder that is characterized by a muscle spasm that can be caused by the toxin produced by an anaerobic bacteria, producing bacteria, that is the Clostridium tetani, which is usually found in the soil. So the incidence of tetanus has dropped greatly because of the universal vaccination with the tetanus toxoid. However, most patients that present with tetanus have a history of a lack of full series tetanus toxoid immunization or inadequate prophylaxis following a wound. There is no true incidence. It's known because tetanus is not a notified disease in most countries. However, according to data from the global burden of disease, an estimated 48,000 to 80,000 deaths occurred from tetanus worldwide in 2016. So most people think that they can get tetanus from just stepping on a rusty nail. Well, this is true. You can also get tetanus easily from just a small cut. All you need to do is to get a break in the skin, then the penetration of the bacteria. So a break from the skin, and also you can equally get it from a dog bite or just any cut by any object. So the bacteria that causes it is the Clostridium tetani, which is an obligate anaerobic motor gram stain bacteria. It is non-capsulated and it forms spores that can resist heat, desiccation, and infection. And these bacteria is readily found in the environment. You can get them on the skin, dust, intestines, feces, and even the saliva of animals. And these spores can persist in the environment from months to years. So in order for the spores to germinate, you will need an anaerobic condition, such as a wound with low oxidative reactive properties. So a dead wound, a foreign body, there should be an infection or a devitalized tissue. So under these conditions, these anaerobic conditions, the spores can germinate and produce two toxins, which is the tetanus, lysine, and tetanus spasm. The tetanus spasm is what is responsible for the clinical manifestation we'll be discussing this afternoon. However, there's also tetanus lysine, which causes hemolytic properties, but the role in the clinical tetanus is not well known. So this pathophysiology will be mainly about the tetanus spasm. So when the conditions are adequate for the spores to germinate, a tetanus spasm is released and it binds to the presynaptic motor neurons, which travels by a retrograde axonal transport from the contamination site to the spinal cord and the brainstem within 2 to 14 days. So when it gets to the place of destination, it binds to the central inhibition path neurons and hence binds to the neurotransmitter, that is the GABA containing and the glycine containing vesicles. So these comes to bind to inhibition, the inhibition pathways, blocks the neurotransmitters. That means the neurotransmitters cannot be released, resulting in the loss of inhibition functions. So the inhibitory, motor, and autonomic nerves, neurons will be lost in this process. So with the loss of these central inhibition, there could also be autonomic hyperactivities. That is uncontrolled, leading to uncontrolled muscle spasm and contraction in response to stimuli such as noise and light. So this is to say that when there are some external stimuli such as noise and light, in addition to the loss of the central inhibition, there will be uncontrolled muscle spasms and contraction. You could also have it manifesting as a muscle rigidity in tetanus, occurring from a whole complex mechanism where there's an increase in the resting firing rate and the disinhibition motor neuron, also leading to the reflex motor responses to an afferent sensory stimuli. So the lack of the neural control also affects the adrenal release of catecholamines, which is induced by the tetanus toxins. So result in some hypersympathetic states that can manifest as sweating, tachycardia, hypotension, and sometimes to hypertension. So it's to know that once the tetanus toxin is fixed to a neuron, it cannot be neutralized by any antitoxins. So our main aim is to prevent those that have not been neutralized or those who have not been fixed to a neuron. So the main aim of treatment will be to attack those that have not been fixed to the neurons, yes, those that like the free toxins here. And also, in order to recover from this, we will need to a new nerve terminals need to be created, a new synapses, because once the tetanus toxin is fixed to a neuron, it cannot be neutralized. So because Clostridium tetanus cannot grow in healthy tissues, we will need some factors to be present in order for the tetanus to manifest. So there should either be a presence of an absence of antibodies, that is an inadequate vaccination history, plus one of two of the following. So a penetration wound resulting in inoculation of the tetanus spasm. Then also we also have co-infections with other bacteria, devitalized tissues, foreign bodies, localized ischemia. And these same factors are some of the reasons why we can have tetanus in neonates. That is when there's an infection in the umbilical stump. Also in diabetes patients that have infection of the extremities, infected extremities with ulcer, and also patients or people that do illicit drug injection. So approximately the incubation period is 8 days, but it ranges between 3 to 21 days. And tetanus can present in 4 forms, which include the generalized, the local, the cephalic, and the neonatal. However, the generalized is the most common. So with that, 80% of the patient will present with a trismus. And a trismus is a mild or severe spasm of the lower jaw. Then they can present with the autonomic overactivities that manifest, such as the sweating, tachycardia, hypotension. Then there's also, they can present with both the tonic contraction of the skeletal and intermittent muscle spasm. Now these spasms are quite painful because there is no loss of consciousness or impaired consciousness in people that present with tetanus. So the contractions and the spasms are intense, painful. So the tonic and periodic spasm contraction are what is responsible for the other signs we pick up, that is the stiff neck, opisthotomus, restus sardonicus, a ball-like rigid abdomen, dysphagia, periodic apnea, and upper airway obstructions. So the local tetanus, it is rare. It's also presents as a tonic spasm muscle contraction in one extremity or body region. So this presents as the part that is affected, meaning if the cat is at the left leg, we expect the spasm to be at the left leg. However, most of this often evolve into a generalized tetanus, and its diagnosis is somehow difficult. We also have the cephalic tetanus, which also presents after there is an injury to the head or neck, and mostly affects the functions of some of the cranial nerves. And however, that one also evolves to the generalized tetanus and may also present with dysphagia, trismus, and some facial nerve neuropathies. Commonly, the facial nerve that is affected is the facial nerve. And this one can be mistaken for stroke if you do not take a very good history and make a good diagnosis. Neonatal tetanus is typically seen in infants during the 5 to 7 days. The onset is rapid. That's because the axonal length is proportionally shorter in infants. And the first symptoms or sign that we picked up is a patient that's refusing, or a neonate that's refusing to feed or have difficulty opening their mouth or having a trismus. So a patient that was previously feeding, able to feed well and quite normally, presenting difficulty to feed. And also sucking may stop. Now, this neonatal tetanus is common among us because of some of the practice we have. So first could be from a mother who has not been vaccinated against tetanus. In this way, the newborn will not get the passive immunity from the tetanus. And also some of the practices that happen, so cutting the umbilical stamp with an unsterilized instrument. And some mothers also apply some sort of chemicals or dark substance onto the umbilical area, trying to increase healing there by causing infections and probably tetanus. So the neonates will present with hands that are often clenched and feet doxyphilus in an increased tone. And also with progression of the disease, the neonates will become rigid and opisthotomus may develop. So I think the next slide just shows the trismus, how someone will present with a trismus looks like. So it's just a mild to severe spasm of the lower jaw, making it difficult for them to open the mouth and also to swallow. The next slide shows a patient that is, the first one is in an opisthotomous position. That's a severe spasm of all the muscles of the body. It's a form of a high arched back. And the last one is that of a neonate in the same position. So to diagnose tetanus is mainly clinical. So you should have a high index of suspicion when you see a patient with this presentation, and also a good history of an antecedent tetanus-prone injury, and also a history of inadequate immunization for tetanus. So if you get a patient that will present with all these things and you're able to pick up a good history of patient that has not been fully vaccinated for tetanus or has had inadequate immunization, you have a high suspicion of injury for tetanus. So there are some few conditions that also have some tetanus mimics. So the first one will be trismus due to dental infections. So there are some patients that have dental abscesses, that may present as tetanus symptoms. So you need to find out if there was any dental issues before the presentation of all these symptoms. Then we have drug-induced dystonia, such as those that's due to phenotizide. So these patients have deviation of the eyes and some weakening movements of the head and neck. They also have these contractions, but they have some absent tonic contractions and spasm. To differentiate this from tetanus, it will be the fact that the tetanus patients do not have deviation of the eyes. Yes. And such therapies, that is the phenothiazer do not, the therapy, that is the bentropin, the bentropin mesylate do not have an effect on tetanus. So that is one thing to use to differentiate it. Then we have strychnine poison, that is due to injection of rat poison. So you have to pick up a history whether they have these poisons at home and the patient have mistakenly taken it for whatsoever, whether in an attempt to commit suicide or by accident. You have to rule out poisoning. We can also talk of malignant neuroleptic syndrome. That is associated with the use of antipsychotic agents, and it's characterized by distinct mental state changes, rigidity, and fever. Now, this can also be differentiated from the tetanus because the tetanus do not have its affecting consciousness level. Then there's also a stiff person syndrome. That is a rare neurological disorder characterized by severe muscle rigidity. Now, this particular syndrome has a rapid effect when you give a diazepam. So to the management, it is multidisciplinary approach. So the goals of the treatment is halting the toxin production to neutralize or neutralization of the unbound toxin, airway management, the control of muscle spasm, management of the dysautonomias, and also the general support management. So the first part is halting the toxin production. Now, there's a wound, we need to manage the wound. This is one of the main stages of managing the patient as a whole. If the wound management is not properly done, the rest of the management will not be, like the management goal will not be achieved. So you need to do an intense wound debridement to eradicate spores and necrotic tissue, which can lead to further contaminations or spores formation. So this part is really crucial. So we need to do a serious wound debridement as one of the main treatment goals. Then also antimicrobial treatment, preferably metronidazole is given, but penicillin is also safe and effective, and the treatment can be given within 7 to 10 days. But the antimicrobial therapy would again fail if there is no adequate wound debridement, as stated earlier. So in case of mixed infections, you can give a first, second, or third generation cephalosporins. Alternate agents can be doxycycline, macrolide, clindamycin, vancomycin, and chlorphyricol. Now, the next goal is neutralizing of unbound toxins. So we learned earlier that once the tetanus toxin is bound, it cannot be reversed. So since the tetanus toxin is irreversibly bound to the tissue, only the unbound toxin is available for neutralization. So the main aim there is to tackle on the unbound toxins. So a passive immunization to neutralize the unbound toxin is associated with improved survival. So immediately we need to give the intramuscular IM antitoxin intramuscular antitoxin, that is the human tetanus immunoglobulin. So that is the safe and the choice of antitoxin to give to neutralize the unbound toxins. Then Also, an active immunization can be given, since the tetanus is one of the few bacteria that do not confer immunity following recovery of illness. All patients with tetanus should receive the active immunization with a full series. So we'll talk about this more at the prophylaxis part. Then we need to control of the muscle spasm. Ideally, patients that have been diagnosed of tetanus need intensive care, but in our setting, intensive care is not readily available. So it will be better to nurse such a patient in a quiet, dark room. Then you can give the benzodiazepine to control the rigidity and spasm that is associated with tetanus. So diazepam is mainly used, but if it is not, the sedation alone is not adequate, that is when a neuromuscular blocking agent such as the vericonium or pancuronium can be given. However, to give these medications, you need an intensive care unit, and since we don't have that, you can equal titrate the diazepams with baclofen to get a good response. Magnesium sulfate has been seen to have some effect in the management of tetanus by acting as a presynaptic neuron blocker by blocking the catecholamine release from the nerves and reduce the receptor responsiveness to the catecholamines. So in such way, it will prevent or be able to block some of these sympathetic responses that we get, such as the profuse sweating, tachycardia, hypertension. Yes. Another way to prevent or to help with the management is the airway management and the supportive management. Now, these patients with tetanus may have to be in the hospital for long, or be having prolonged, they'll have to stay in the intensive units for long, or in our wards for long, since you have no intensive units, and may need some form of mechanical ventilation. And such patients are highly predisposed to nosocomial infection, thromboembolic diseases, decubitus ulcers, and gastrointestinal hemorrhages. So we'll have to take precautions against all these predisposing factors whilst on admission. So endotracheal intubation is justifiable. However, because of long stay, early tracheostomy is frequently done because of the prolonged mechanic ventilation. And it will be good to also do the nutritional support, which is mandatory. And the best is the enteral feeding, which is preferred. And also we have to give some prophylaxis with PPIs to prevent gastroesophageal hemorrhages from stress ulcers. So we have to also cover up prophylaxis for thromboembolism with anticoagulations. So this anticoagulation should be given early to prevent these thromboembolic situations. Then also, as soon as the patient has improved and you are not seeing spasms or the spasms are ceasing, it's better to initiate or to start early physiotherapy in order to prevent prolonged muscle wasting and contractures. So this is a table for tetanus prophylaxis. Now, this table has been divided into clean or minor wounds, dirty or severe wounds. So now, the tetanus toxoids, if looking at the EPI, that's the extended program for immunization in Ghana, you take three, you have 3 dosages or 3 times to take the tetanus toxoid injection, and also you take the booster along the line. So we'll be using 3 as our cut point here. So if a patient has 3 or more tetanus toxoid dosage and has a clean wound or a minor wound, and the patient, and you take a history, the patient hasn't had a booster in the last 10 years, you would have to give tetanus toxoid injection, but no tetanus immunoglobulin, that is the ATS. So such patient will only receive the TT. But if the patient, same scenario where the patient has received 3 or more tetanus toxoid dosage, but the wound is dirty or is a severe wound and has had or hasn't had any booster in the last 5 years, you will still take only the TT, but no tetanus immunoglobulin. Now, if there's a patient that would not know about his immunization status and has received less than, has received less than 3 of the tetanus toxoids dosages, and the wound is clean or minor, this patient will have to receive only the tetanus toxoid containing vaccine and no tetanus immunoglobulin, or that's the ATS. But with this same patient whose immunization status is unknown and has received less than 3 tetanus toxoids, this patient will be given both, and the wound is dirty or severe, will be given both the tetanus toxoids plus the tetanus immunoglobulin. Because this one, so we know that this wound is dirty, and the person has a more likelihood chance of getting tetanus. It would not know of the immunization status. So we have to give the tetanus immunoglobulin to go and bind to the unbound toxin to prevent binding to the, to cause the whole binding to the presynaptic neuron, going all the way to bind to the, to prevent the inhibition pathways and getting the contractions and spasms that presents in tetanus. So now, with the prognosis, the case fertility rates in neonates, or in non-neonates, in Bristol's limited regions ranges from 5 to 10%, whereas majority of patients with tetanus that have modern supportive care, as in a well-resourced facility, it's good compared to those in a resource-limited countries with a rate of 5 to 50%. However, with neonatal tetanus, once a patient has it, it is nearly fatal with 3 to 88% mortality rate. Now, a patient or a neonate that may survive this in the long run might have some neurological damages that may further present as a minor intellectual deficit to cerebral palsy. So since Clostridium tetanus spores cannot be eliminated from the environment, immunization and proper treatment of the wound and traumatic injuries are crucial for the tetanus prevention. And we know that these tetanus vaccines are safe, effective, and important for all people of all ages. So this is just from the Center for Disease Control. So this just shows people of all ages the tetanus vaccine they can get. So for the young ones, then for the preteens and the adult that will receive a booster every 10 years. This next slide shows the extended program of immunization Ghana 2020 that showed that at the time of the ages where a child goes for immunization. So for us here, we start at 6 months, 10 months, and 6 weeks, 10 weeks, and 14 weeks, where the patient gets the penta or the DPT and the Hep B and hemoglobin influenza, I guess. But that's the combination. So for in our EPI, the child gets it at 6 weeks, 10 weeks, and 14 weeks. So now, these are my references: up-to-date, Medscape, Center for Disease Control and Prevention, Ghana Health Service, or Ministry of Health, Extended Program on Immunization 2020. Thank you.
All right, thank you, Dr. Mabel for a great job done. And thank you for staying to join us all throughout this presentation. If you look in the chat box, I've just put up a link in there. If you want the slides of what Dr. Vivian has just presented, you could click on the link provided so that you would evaluate our output for today, and then you can put in your details so that the slides will be sent to you. As well, if you want to make use of the chat box to put up any questions or comments or suggestions that you may have, it's still available. You can do that. But once we are at the end as well, if you have a question that you want to ask, kindly unmute yourself and then you can go ahead and ask. You could electronically raise up your hand and then I would unmute you to talk. So going through the chat box, Donato says, wonderful presentation, Dr. Mabel. She did great. I don't see any other chat or any other question in the chat box. If you have a question, kindly electronically raise up your hand and you could go ahead to make your submission. Okay. Ahmed, please go ahead. You can unmute yourself and then give us your response. Okay, Ahmed has lowered his hand. He didn't unmute himself as well. If you have any question, please go ahead, electronically raise up your hand and then I would ask you to unmute yourself. Okay, so whilst we wait for any questions, if there may be, just some few points for us to note. I was particularly happy that she mentioned that tetanus is not only in rusted metals, which ironically our advert for this presentation did put up. So other than just rusted metals, even on grasses, you can have the spores being there. Commonly they are in the soil. And on any surface at all, you can have a Clostridium tetani spores. So obviously the most important aspect of it is having to get yourself fully vaccinated. And if you aren't fully vaccinated, we encourage that that should be done, especially those who have not gone through the EPI, the standard program on immunization, where you'd have received the 3 shots and 10 years after which you may need a booster as well. Good enough, the way our the females are advantaged in this area, especially those who get pregnant and attend antenatal care, because then as part of the ANC visits, you get to receive at least about 2 shots of the tetanus injection, so that then you probably get 5 or more, which virtually confers immunity for life. So those who probably work in high-risk zones, like agricultural workers, like those of us who work in the hospitals, especially with exposure to sharp instruments, it's usually advised that you take the full vaccination schedule. And like you saw in the prophylaxis that she put up, the schedule of it, definitely we try to categorize the wounds as clean or dirty depending on the nature of the wound and how deep it is. And the deeper the wound, the more the risk of tetanus. The cleaner the wound, the less likely. Also, we will look at how many shots that you have had, like she rightly put up as well. At where there's a bit of ambiguity, what I just want to stress is that usually we err on the side of caution. So if you don't know that the person has received 3 or more doses, you treat it as uncertain, just like you saw, and where the person will definitely have to receive the TT. And then if the wound is severe enough or it is a dirty wound, definitely you have to add the anti-tetanus serum, as we always do. As well, tetanus is a clinical diagnosis, like she mentioned, in any form of it, whether it's a generalized form, whether it is the cephalic form, or whether it's neonatal tetanus. Most of it is what you pick up clinically. And the management as well is supportive care. Is just making sure that the person does not get a respiratory failure, respiratory support, where there's an intensive care unit, definitely want to nurse in such an environment. Good enough in the Upper West, we have a 7-bed capacity intensive care unit fully furnished. So obviously these are things that you should nurse the patient in. And then also about treating, so antibiotics are routinely recommended for everybody who you suspect to have tetanus, more especially with the anaerobic coverage with metronidazole. So we should always attempt to do that as well. And then the thromboembolism, you may be doing all the right things, then the pulmonary embolus will kill your patient. So usually in the setting of infections, and like we always say, all chronic medical diseases, on admission, we give thromboembolism. For all you know, most of the times, if you follow the pathologist or you go for autopsy, more than 50% of our patients actually die from pulmonary embolism, not that the condition that you actually are treating the patient for probably killed them. So it's something for us to be mindful about. And like she mentioned again about the toxin, once it gets bound, that is it. So our sure bet is to prevent the toxin from getting inside. So in addition, one of the things is usually to make sure that you debride that wound. You take out all the dead necrotic tissue, and then you thoroughly clean the wound. You clean it so that then the inoculum does not still stay in there and keeps getting bounded. That's a way of preventing the toxin from being produced in the first place. Then once the toxin is there, is to neutralize with the ATS, like she mentioned, and then as well to vaccinate the person appropriately. We control the other clinical symptoms with the supportive care. So if it's the spasms, benzodiazepines. As well, if there's respiratory compromise, obviously in the ICU, sometimes we have to intubate, like she rightly said. Sometimes there's also autonomic hyperactivity, and when it is such, we may need to control the BP with either labetalol or any of that. And if there's a bit of aggression, sometimes we add in morphine. And then she did add about the magnesium sulfate beta as well. So these are some of the things that we should take home from this presentation. But more importantly, prevention, prevention, prevention. Very easy to prevent, very easy disease to keep the incidence low like we see in the developed world. And so these are things that as clinicians, we should be mindful about and treat our patients appropriately. Great. So just going through the chat box, Abdul Rahman says, wonderful presentation. And then Silas is asking for the link again. Okay, I'll just post that up again so that you can, if you want the slides to be sent to you, you could click on that link, provide the evaluation responses, provide your email, and then we can send this to you. So Silas, I've put up the link again for you to be able to access that. I don't see any question in the chat box. I don't also see any hand up. So just give a grace period of 5 minutes. If you have any question, please electronically raise up your hand or make use of the chat box. Okay, Abdul Rahman, please go ahead.
Yeah, good evening. I don't know whether I'm clear.
You're loud and clear.
All right. Yeah, thank you very much for the wonderful presentation. Actually, I don't have any question. It's more or less a suggestion or an addition. Regarding wounds in tetanus, I ever encountered a case in one of the remote areas in northern region. And the man couldn't remember actually experiencing any wound or any cut. So it was a bit difficult. And I was happy she stressed on the fact that tetanus is mainly clinical. So we need to, widen our index of suspicion of it. This particular client I'm talking about was about 50 years or so. I think the only symptom he had was neck pains. There wasn't even a stiff neck or locked jaw. And when we were taking the history, we wanted to be sure. So we're trying to find out whether the he had ever, sustained a cat. And the man was categorically no that he never encountered anything like that. Only for some, I think 2 days later, for him to start exhibiting this opistotal, and then some Jackie actually gave him the tetanus toxide alongside the immunoglobulin, and he was better. So I think that was what I just wanted to add. Thank you.
Great, good one there, Dr. Rahman. That's very true. So what you talked about is what is referred to as cryptogenic cases of tetanus. Although, like most cases of tetanus, the obvious antecedent event is always there. Whether it is a cat, any of that, either grass, had a cat with the grass or any of so. But some minor abrasions and some unnoticeable skin injuries can predispose to tetanus as well. So really, like you said, if once the clinical features are there, you treat as such. And then obviously if the immunization status is unknown, you treat as Dr. Mabel mentioned. Either if this is a clean or minor wound, you go ahead to give your TT. If it is a deeper wound or severe wound or dirty wound, you go ahead to give both the TT and the ATS. So we always try to err on the side of caution, like you saw in the table. So that's good that you brought this. This is what is referred to as cryptogenic cases of tetanus. Even in the developed world, these are things that have been documented in tetanus case series. Great, thank you for bringing that up. Any other person with any question, you could electronically raise up your hand and then you can go ahead with your question. Someone with Galaxy A32 say, in the case of prophylaxis, is there a window period to give the TT? Dr. Mabel, do you want to respond to that? Your microphone is muted.
Doc, is the question again?
Is there a window period for TT, for tetanus toxoid, in the case of prophylaxis?
Yeah, that is what we give to the patients, even. So it's the TT is what will give the immunity that we need. So for the prophylaxis, that's the main intramuscular injection we give, even with patients that have the clean wound, dirty wound, or whether we know whether they have been immunized or not, we give the TT for prophylaxis. It is the immunoglobulin or the ATS that we need to find out whether the wound is dirty, severe, and also want to know if he has not received the immunization or he has received less than 3 of the immunization, but the TT is given to them all.
Okay, so in direct response to his case of a window period, once you are thinking about prophylaxis in the case of the wound, you err on the side of caution, like we keep saying. So for whether it's a clean wound or a dirty wound, once it's a wound that you think you are going to give prophylaxis for tetanus, the TT is always given. So there's no window period. Once the patient presents to you, you would go ahead. Except in cases where you think he's had enough of the injections, that's about 5 or more. Sometimes people, and the case is not a classical presentation of tetanus or risk for tetanus. But even with that, you need to monitor. In our environment, I will encourage that we are on the side of caution by giving the TT without a regards to any particular period of time. Like Dr. Mabel mentioned, it's the ATS that really want to know whether how many shots of the TT you've had previously and whether the wound is clean or dirty. Again, anytime there's a bit of ambiguity, please err on the side of caution. Where if you are uncertain how many doses he has had, if you are uncertain whether this wound is a deep wound or clean, err on the side of caution by giving both the TT and ATS. The thing is that most of our facilities, when you go, even with the smallest of cats, even with full immunization, they give you both of them. Of course, guidelines do not support that, but we always say that guidelines are made for the people, not the people for the guidelines. If you adapt it to your local environment and you know that probably it will take time to get the immunization settled. The patient does not even know what you are talking about in regards to when he's had the shot or not. Safe to give both of them. All right. Abu Bukari says, can you explain how to get the vaccine? I don't know where you are, but obviously the public health people have TT everywhere, and most of our emergency settings have TT. And like we said, the childhood vaccination schedule, this is readily available in every community, the community-based health planning services, the CHIPS centers. So really, the vaccine availability, I don't think it's a problem in our environment. And these are free vaccines that are on the EPI. Right. Sefako, I see that you are on mute. Please go ahead. Dr. Sefako. All right. I think probably she did it in error. Any other question? Dr. Amina Mohammed, I provided a link that you would click. When you click, then you put your email address in there, and then the slides will be sent to you. I just saw that in the chat box, you put your email there. I'll put up the link again so that, because out of this meeting, I'll not be able to send it rather than looking at what has been provided via the link. So what I've put in there, kindly click on that, and then you can provide your email address at the end of the evaluation. Thank you. Okay, so I guess we've been able to make a good contribution to the management of tetanus. Okay, I see that George's hand is up. Please go ahead. Please unmute yourself, George, and ask your question.
Okay. Thank you very much for the presentation. I joined late and maybe my question might have been responded previously, but I want to find out if you encounter a child who is still thinking, undergoing the CWC with a wound, and maybe the child has taken maybe twice of the TT. Is it advisable to give the immunoglobulin, or we should wait whilst the child is taking the TT? You should stop it and let the child continue the EPI management. I don't know if I'm clear.
Yeah, you are very clear. So if you could kindly look on what Dr. Mabel has projected, what you are talking about would come directly under unimmunized or uncertain or less than 3 tetanus doses. That's the second row of the table. That's exactly where that child will fit in, because less than two shots means less than 3. So the next thing to ask yourself is, this wound that the patient or the child is presenting with, is it a clean or minor wound, or it is a dirty or severe wound? Those are the 2 questions to ask yourself. If you think that it is a clean or a minor wound, then you can go ahead and give the TT at that instant, at when you are meeting the child, and he will continue with the rest of the injection based on the EPI, age appropriate, i.e. the 6, 10, 14, if he hasn't completed those series. Obviously, if you say 2 shots means that he has not completed this series, and meaning that this child is less than 14 weeks, that's exactly what you are saying. Because, except if the mother decided not to go for the CWC for the various vaccines, because given 6, 10, 14. So this child of less than 14 weeks who has had only 2 shots at 6 weeks and at 10 weeks, definitely, if the wound is clean or is just a minor abrasion, you go ahead to give the TT, and then you complete his EPI subsequently. If the wound is a dirty wound, you go ahead to give both the TT and the ATS, and then you complete his vaccination schedule. George, I don't know if that gives you a good response to your question.
Yes, Doc, I'm clear.
Great.
Thank you very much. Okay.
Welcome. So Abu Bakari is also asking us, please, does ATS have side effect? Like every immunoglobulins you can have, or any vaccine, you can have some side effects of usually your body's response to the immunoglobulin, but these are usually just a Yeah, sorry, I think my network dropped. So like I was talking about, is usually with side effects regards to any immunoglobulin that you give at all, like a bit of the headache, the fever, and all of that, not untoward. But those mostly with the side effects are the non-human immunoglobulins. But these again have like the equine ones and all of that. But the mostly now what is readily brought in is the human immunoglobulin, and that has very less of the side effects. The other ones, people used to have a lot of allergies to them. So that's like a response directly to the question that you put up. Because I went off, I don't know if anyone has put any question in the chat box before, because I don't see anything. If you have, please report it there, because the network went off. Because for now, I don't see. Or you could just, instead of taking your time to type again, you could just unmute yourself and ask. I think that makes life easier. The floor is open. Just unmute yourself and go ahead with your question if you have any. And just before I went off, I realized some people again put up the mails in the chat box. So you could click on the link I've put up again, and then you can submit your mails via that for the slides to be sent to you. All right, so in the absence of any questions or comments, I think we've done well within the 1 hour. Dr. Mabel, do you have any closing remarks? You could unmute yourself and then go ahead. All right, so thank you so much for joining us for today's meeting. Hopefully next week, Thursday, we would come your way with another presentation. Please take care and God bless us all. Bye-bye.